The term lung cancer, or bronchiogenic carcinoma, refers to malignancies that originate in the airways or pulmonary parenchyma. This sketch will present an overview of the risk factors, clinical manifestations, and histopathology of non-small cell and small cell lung cancers, which comprise about 95% of the cancer types you'll find in the lung. And because of all this talk about large cell and small cell, we're headed to prison. And not just any prison, my friends. Welcome to the Rock. On June 12, 1962, 3 inmates, Clarence Anglin, John Anglin, and Frank Morris, made the first and last successful attempt to escape Alcatraz Island. It's gone down in history as one of the most intricate prison escapes ever devised. But before we get into that story, a few statistics regarding the inmate population here on the island. In the U.S., lung cancer occurs in more than 200,000 patients annually and causes over 160,000 deaths in that same amount of time. So, although it's not necessarily the most common type of cancer, lung cancer is still the leading cause of cancer-related death. In women, breast cancer is the most common, but lung cancer is the most deadly. And in men, prostate cancer is the most common, but again, mortality from lung cancer is much higher. Before we dive into lung tumors, you should know that by far the most common cancers found in the lungs aren't even made of lung tissue. Most cancers are actually metastases from other parts of the body, especially from the breast, colon, and kidneys. In this scene, however, we're going to focus on the most common primary tumors of the lung: small cell, adeno, squamous cell, and large cell carcinoma. Okay, so as you can see, the prison staff is on high alert because they received an anonymous tip that the prison break is planned for today. Well, most of the staff is on high alert because it looks like a couple guards have found some time for their usual leisure activity: high stakes dice. Ah, yeah. You should recognize the dice, by the way. Those risky red dice are a recurring symbol for risk factors. And if you can't tell already, by the ashtrays and smoke filling the room, smoking tobacco products is the most important risk factor for the development of lung cancer. In fact, about 90% of all lung cancer is considered attributable to a person's status as a past or current smoker. So remember, the most important part of lung cancer prevention involves preventing people from starting to smoke, or helping those who already smoke to stop. All right, so obviously, smoking is the big risk factor to remember here, but there are a few others to keep in mind as well. Radiation therapy to the chest, for example, can increase the risk of developing lung cancer in patients who are being treated for other primary cancers, such as breast cancer and Hodgkin lymphoma. And that's why we've included our recurring radiation symbol here, on the microwave in the back. Whether it's from interstitial lung disease, adverse medication effects, or environmental toxins, pulmonary fibrosis also increases a patient's risk of lung cancer. Just take a look at the fibrotic, though meticulously pruned, pulmonary bonsai tree on the break room table. Remember that jailbreak I mentioned earlier? Well, unbeknownst to the guards here, it's already well underway. Though it looks like it's not off to a great start. As he breathes in that very much up-to-code 1960s wall insulation, remember all those environmental toxins that can increase lung cancer risk, such as asbestos. I know what you're thinking. Oh yeah, asbestos. That causes mesothelioma, right? That nasty plural thing? Asbestos exposure is the only known risk factor for malignant mesothelioma, yes, but bronchogenic carcinoma is actually drastically more common. Add smoking on top of that, you're talking about a synergistic effect leading to an almost 60-fold increased cancer risk. Keep other workplace exposures in mind as well, like radon, metals, and aromatic hydrocarbons, not to mention industrial chemicals like chromium, cadmium, beryllium, and arsenic. Always bring a face mask to a prison escape. I think the lesson is here. So what kind of clues should you look for to know that lung cancer has broken out of its cell and is invading your patient's lung tissue? First, you should know that not only has Alcatraz prison been around for a long time, so have a few of its oldest officers. The peak incidence of lung cancer occurs in the 5th and 6th decades of life, slightly on the older side. The majority of patients with lung cancer have advanced disease at the time of clinical presentation. So, although a significant proportion of lung cancers are found incidentally on imaging, a majority of patients are going to present to your clinic with symptoms. These symptoms may result from local effects of the tumor, from regional spread to tissues, or from distant effects. We're talking paraneoplastic hormones, which we'll illustrate later on in the sketch. Patients with lung cancer classically present with progressive dyspnea. See how out of breath that guy is? And weight loss, as evidenced by his ridiculously thin physique, decreased appetite, hence the food tray falling to the ground, and chest pain, especially in younger patients. Why the cake, you ask? It's the warden's birthday. As awkward as ever this year. Not a party person. If you take a look around her desk, you'll notice a few symptoms that can arise when a tumor starts affecting larger, more central airways. Hence the central bronchial air duct coming from the ceiling. Look out for cough and wheezing. Yup, we're bringing back our wheezy party blower. Dude, take a hint. You're being weird. Also, you see that streamer with the recurring bacteria pattern? It's meant to remind you of a recurrent pneumonia, occurring in the same anatomical location of the lung, over and over again. This should raise your suspicion of a localized airway obstruction causing post-obstructive pneumonia. Bronchial involvement can lead to hemoptysis as well. So we've added some unsettlingly sanguineous fluid dripping from that bronchial air duct. All right, let's break down lung cancer into its pathologic subtypes, each with its own unique epidemiology, clinical characteristics, and histology. First thing to note is that about 95% of lung cancer can be divided into two groups: small cell lung cancer and non-small cell lung cancer. Small cell lung cancer will be illustrated here, in this small, solitary confinement cell. And the non-small cell lung cancers? There are three subtypes to know. Squamous cell carcinoma will be drawn in the adjacent cell. See that squamous epithelium-evoking tile? More about that in a little bit. Adenocarcinoma will be illustrated over here, at the dining den, the name the prisoners have given to the Alcatraz cafeteria. And lastly, large cell, embodied by this respectfully large inmate, affectionately called by his cellmates, Snuggles McTicklepants. Yes, it's best to not ever make eye contact, and no, it's not the good kind of tickle pants. You haven't been here long, have you? The location of these tumors can be broadly classified as being either more central or more peripheral. The central tumors, small cell and squamous cell, both start with S, so remember S for central. We also tried to convey their central location by placing these two cells under that bronchial central heating vent coming from the ceiling. Large cell and adenocarcinoma, on the other hand, will often occur more peripherally in the lung. Now, let's address smoking again. Smoking increases your risk of all these cancers, but some of these are essentially only seen in smokers. You're almost never going to see small cell and squamous cell cancers unless it's in a smoker, for example. So let's draw in some cigarette smoke wafting in from upstairs. S stands for three things now: squamous and small cell, centrally located, and smokers. These two show the strongest association with tobacco exposure. Non-smokers can get lung cancer too, though. And the pathologic type you're most likely going to see in patients with no smoking history is adenocarcinoma. So what's the number one rule at the dining den cafeteria? No smoking, of course. Adenocarcinomas are also the most common type of lung cancer in women and patients under 40. So the lunch lady at the dining den is on the younger side. It's only part-time. Not only is adenocarcinoma the most common type of lung cancer in non-smokers, it's just the most common type of lung cancer in general. That means smokers too. So let's draw in one of the inmates here, putting out his cigarette in protest. Right on the sign. Adenocarcinoma is derived from glandular tissue, or tissues with glandular characteristics. So you can bet that on the test, if they show you a slide of adenocarcinoma, it'll look, well, glandy. The tissue may look acinar, meaning that it contains gland-like excretory units, or it may look papillary, or even mucinous. Just think of this gland-like hairnet, standard lunch lady uniform. Adenocarcinoma, like most cancers, follows a staged progression of cellular changes visible on histology, and we'll simplify it here, behind the lunch counter. The first stage involves what's called atypical adenomatous hyperplasia. All this means is that the lung architecture is completely normal. It's just that the epithelial layers of the airways look a little more cellular, proliferating a bit. And the cells are atypical looking, with nuclear hyperchromasia, pleomorphism, and prominent nucleoli. Let's jump to the next stage, dubbed adenocarcinoma in situ, or AIS. Adenocarcinoma in situ has the word carcinoma in it because we're officially at a malignant stage here. These are cancer cells uncontrollably proliferating. In situ, however, means that it hasn't crossed the basement membrane yet. So, AIS will be illustrated behind that plate of glass. Adenocarcinoma in situ consists of tall columnar cells that spread along the alveolar septa instead of invading. You see how the alveolus-shaped spaces in the lunch counter are lined with those purple blocky cells? It creates a sort of thickening of the alveolar walls. This non-invasive surface alveolar growth is sometimes called a lipidic growth pattern. The word lipidic was invented by the English pathologist John George Adami in 1902, initially meaning rind-like or membrane-like. And in the 90s, pathologists got really creative and associated it with butterflies, or Lepidoptera, lining the alveoli. At Sketchy, we like to think of lipidic leopard spots instead. Again, you'll see those alveolar spaces, but lined with encroaching malignant cells, making the walls look darker and thicker. These cells can be mucinous as well. So let's make her hacking up some gross-looking mucin secretions. Because these malignant cells are only lining alveoli and not invading, a chest X-ray might reveal a hazy consolidation instead of a well-defined tumor. Kinda similar to pneumonia or pulmonary edema. Remember, adenocarcinoma in situ is not benign. That word carcinoma is in there for a reason. Eventually, the basement membrane is crossed, and the cancer invades. So on the other side of the glass, we'll illustrate invasive adenocarcinoma. Adenocarcinoma displays glandular differentiation. So again, it looks, well, glandy, and may form acini and papillae and tubules. It's comprised of globs of cuboidal to low columnar cells, as depicted by that delicious mass of jello cubes. These cells will look hyperchromatic and will have prominent nucleoli. So the flavor of the day is a nice hyperchromatic grape. Look for mucin production as well. Muciny. In fact, there may be copious amounts of sputum production, even more so than in other forms of lung cancer. All right, it's time to move over to the next most common primary lung cancer, squamous cell carcinoma, which comprises about 20 to 30% of all primary lung malignancies. You see that flat squamous tile on the floor? It didn't start out that way. Squamous cell carcinoma develops through a process called metaplasia, which is essentially one cell type becoming another out of necessity. Over years of chronic inflammation, in this case probably due to smoking, the normal respiratory pseudostratified columnar epithelium transforms into the much more resilient stratified squamous epithelium. The normal epithelium, pre-metaplasia, is depicted on the wall of the cell. It's tall and columnar, and when you look at the cross-section, it has the appearance of being multilayered, even though it isn't. That's pseudostratified. Now look at the bottom of the wall. After years of wear and tear, the columnar wall has started to fall apart. As a temporary fix, the guards have installed those stratified metal plates, which should be able to withstand daily wear a bit better. Stratified means there's multiple layers on top of each other. And when you see stratified metal plates, think of metaplasia. The columnar epithelium is replaced with a layer of stratified squamous epithelial cells, and this new surface is better at withstanding chronic injury. Don't worry, this step is reversible, hence the temporary sign. Just a temporary covering until the wall is rebuilt, and the columnar epithelium is allowed to regenerate. If the irritant is not removed, however, metaplasia continues and it just gets worse from there. More ominous than metaplasia is dysplasia. In this scene, when you hear dysplasia, think of this disgusting squamous tile. Disgusting dysplasia. Dysplasia means you're going to see disordered squamous cells all over the place instead of in neat layers. Their nuclei look weird and really dark, and you may also spot some mitotic figures, which means the cells are dividing. Looks disgusting, right? From there, it's similar to what we described with adenocarcinoma. Squamous cell carcinoma in situ means the cancer has yet to penetrate the basement membrane. Once that basement layer is breached, Welcome to invasive squamous cell carcinoma. Some neoplasms will show features of very well differentiated squamous cells, including the formation of keratin pearls and intercellular bridges, kind of like the intercellular strings connecting these pearl necklaces. Ooh, a secret hiding nook under the tile? Score! What have we got here? Some spare shivs, nice. Oh, and some human remains. That's, fun. On second thought, let's just, cover this up and keep moving. That necrotic skull at the bottom of the cavity, by the way, should remind you that large tumors may exhibit central areas of necrosis, which can lead to cavitation. Remember, we're in the central cell block here. So, naturally, squamous cell lung tumors tend to form centrally from large bronchi. This can lead to all those central symptoms we talked about, including cough, shortness of breath, and hemoptysis. Let's head over to the adjacent cell, where we'll get to meet small cell carcinoma, the primary lung tumor that confers the worst prognosis. That's right. This small solitary confinement cell holds the most dangerous inmate on the entire island. Under the microscope, small cell carcinoma tumors are comprised of small, oval-shaped cells with scant cytoplasm. In other words, you'll see diffuse sheets of little round basophilic blue cells. It's depicted by all that bubble wrap they've installed around the cell. Yeah, that's right. The whole thing is padded. Told you this guy was crazy. Don't worry, though. Feel that wall. Right there. Go ahead. That's solid granite, my friend. Now, I want that granular surface to remind you of two things. Number one, the nuclear chromatin inside these little blue cells is often described as granular or salt and pepper, just like the pattern in this granite. And two, small cell carcinomas can display varying degrees of neuroendocrine differentiation. In fact, immunohistochemical stains are frequently positive for neuroendocrine markers, one of them being chromogranin. Chromogranin granite. Need I say more? We can stain for other neuroendocrine markers as well, such as synaptophysin and neurospecific enolase. So that's why we've installed this neuroendocrine wiring here, around the cell. I mean, at this point, you should really just call small cell carcinoma a neuroendocrine tumor, because as you'll soon see, these cells just love to secrete all kinds of hormones into the circulation to cause systemic paraneoplastic syndromes. More on that in just a second. There's one more thing you need to know about the inmate we keep in the small cell. The whole reason he was sent to the Rock in the first place is because he's broken out of every other prison in the state. Yeah, small cell carcinoma doesn't like to stay put. Just take a look. He already has some kind of escape plan in the works. In fact, virtually all small cell carcinomas have metastasized by the time they're diagnosed. Not only that, tumor cells are usually located diffusely in both lungs, and therefore are unable to be resected surgically. Just think of how diffuse that small cell bubble wrap is around the cell. Fortunately, small cell carcinoma can be very responsive to chemoradiation, as highlighted by that radiation symbol shining through the window, along with the secret chemotherapy chemistry set we found in his cell last week. He's had a lot of time on his hands in there, apparently. Overall, despite good response to these therapies initially, most of these patients will die from recurrence. All right, it's time to head outside and meet the last of the primary lung cancer inmates, large cell carcinoma. Embodied by, well, there's just no other way to say it. Just an exceptionally large and intimidating dude. Large cell carcinoma is the least common of the bunch, comprising about 10 to 15% of primary lung cancers. And, as the name implies, under the microscope, you're likely to see large, undifferentiated anaplastic cells with huge nuclei and prominent nucleoli. These pleomorphic giant cells are probably derived from adeno or squamous cell carcinoma cells that have become so dysplastic and undifferentiated that they've lost all the features of their former selves. Not surprisingly, large cell lung cancers confers a poor prognosis. They tend to form peripherally in sheets or nests, metastasize early, and are exquisitely resistant to chemoradiation. So there you have it. In general, we still use the historical classification system with two main divisions: small cell lung cancer and non-small cell lung cancer. The latter group consisting of adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. We're going to finish up our tour here with a few interesting extrapulmonary symptoms caused by these tumors. This will involve either direct extension into adjacent tissues or widespread systemic effects that are the result of hormone or antibody-mediated paraneoplastic syndromes. Let's start with regional spread. Spoiler alert, we're going full Shawshank on this one. Lung cancers, along with breast cancer and Hodgkin lymphoma, commonly cause malignant effusions when they involve the pleura or pericardium. So, as our escapee here dramatically leans up to the sky and shouts for joy, what he's really doing is evoking an exudative effusion inside that pleural shirt of his, resulting in a progressive dyspnea. As his heart-shaped briefcase fills with water, remember pericardial effusion as well, which can lead to tamponade. Check out our pleura and pericardium videos for more info. Another interesting collection of symptoms caused by regional tumor spread comprises what's known as Pancoast syndrome. See that plane flying overhead? Pancoast Airlines? Because it's high up in the air, it's the perfect reminder that Pancoast syndrome can manifest when tumors are way up in the apical portion of the lung, in an area called the superior pulmonary sulcus. And in case you haven't noticed, that's an electric fence, with the wiring kind of brachioplexus-y, if you know what I mean. That's because tumors in the superior sulcus can invade the medial roots of the brachial plexus, C8 to T2. This can lead to shoulder pain, neck pain, and arm pain that radiates down the arm in an ulnar distribution. You might even see some muscle wasting in the area of the hand innervated by the ulnar nerve. When a tumor is way up there in that superior sulcus, it can also cause Horner syndrome due to involvement of the paravertebral sympathetic chain. See the chain ganglia running up each side of the spine? These air raid sirens, or should I say air raid horns, even show a few of the classic symptoms of Horner's, including some meiosis on the left there, along with a corresponding droopy-eyed ptosis searchlight. What if the tumor spreads more medially? Now we need to think of mediastinal structures getting involved. So we've included our mediastinal mast there in the background. Running along each side of the trachea in the middle mediastinum are the recurrent laryngeal nerves. See how the reins on the guard's horse here are all yellow and nerve-like, and loop up towards the horse's larynx? No power to your voice box means, you guessed it, a hoarse voice. This red-faced hot air balloon is here to remind you of one last symptom: superior vena cava syndrome, or SVC syndrome. When you tell your patient to raise his or her arms, causing that mediastinal tumor to press against the superior vena cava, venous return is inhibited, causing the face to blow up like a balloon. Okay, so these were just a few examples of the extrapulmonary symptoms that arise due to regional tumor spread. Next, let's jump into some of the most important, and testable, I might add, paraneoplastic syndromes associated with each bronchogenic carcinoma subtype. Starting with small cell lung cancer. Small cell, remember, is pretty much a neuroendocrine tumor that just happens to be hanging out in your lungs. And these cells specialize in secreting all kinds of hormones that can cause a wide variety of systemic syndromes. For example, small cell lung cancer can release inappropriate levels of antidiuretic hormone, or ADH, into the bloodstream, leading to a syndrome of inappropriately high ADH, also known as SIADH. It leads to an inappropriate amount of water conservation, and at Sketchy, we always convey this with an inappropriate amount of water inappropriately spilling on someone's head. Just blatantly inappropriate, okay? Not cool, small cell. Not cool. Just think of this guard here, having trouble replacing that ADH water cooler, getting doused. This can decrease those sodium levels, so take note. If the sodium decreases rapidly, your patient can develop cerebral edema and progress from restlessness to seizures, and even respiratory arrest. Typically, in the long term, treating the malignancy will also correct the sodium. Small cell lung cancer is also associated with Lambert-Eaton myasthenic syndrome, a neuromuscular disorder caused by autoantibodies directed against voltage-gated calcium channels. Just think of these antibody-shaped keys here, kept by the guard. If he could only reach them, so close. To convey that these antibodies are directed against calcium channels specifically, we've got the comically rotund officer here, downing what seems to be a delicious cup of calcium soft serve. The cup's empty, of course, because calcium channels are being inhibited. But he just can't seem to get himself out of his chair. The reason why has to do with this bin of empty acetyl cola bottles under his desk. It's here to remind you that blocked presynaptic calcium channels means decreased acetylcholine release. And now that I think about it, he's providing a perfect example of the proximal muscle weakness that ensues, giving patients difficulty when rising from a chair or walking upstairs. This is a symmetric muscle weakness, by the way, and that's why both of his arms are limply reaching out. Besides this myasthenic syndrome, small cell carcinoma is associated with a whole range of neurological paraneoplastic syndromes, including cerebellar degeneration and encephalomyelitis. So let our recurring encephalopathic brain turban here remind you of these paraneoplastic central nervous system disorders, which can manifest as dizziness, dysarthria, and ataxia. Just like in Lambert-Eaton myasthenic syndrome, what's probably happening here is an autoimmune response against antigens in neural tissue. And looky here, hiding underneath that brain turban are a few antibody keys. It's the last place they'd look. So, when a patient comes to your office with neurological symptoms and a pulmonary mass on X-ray, don't automatically think of brain mets. There could be a few renegade autoantibodies floating around up there. Small cell is also associated with a paraneoplastic Cushing syndrome, caused by ACTH and ACTH-like substance release from the tumor. It's similar to the high ACTH seen in Cushing's disease. So just think of all the symptoms embodied by that rickety hyperglycemic moon face statue from our Sketchy Farm glucocorticoid sketch. For now, we'll just have his massive gluteus plopped on top of our recurring Cushing's cushion. Killer lumbar support on that thing, by the way. All right, let's move on to adenocarcinoma. Over at the dining den, one of the prisoners is getting a little handsy and is feeling the lunch server's wrath. A swift club to the fingers should remind you of digital clubbing. See how round and swollen his fingers are? That's digital clubbing. It involves thickening of the distal fingers with the appearance of round convex nail beds. In hypertrophic osteoarthropathy, digital clubbing is accompanied by sudden onset arthropathy, commonly affecting the wrist and hand joints. It can also involve the elbows, ankles, and knees. The term hypertrophic pulmonary osteoarthropathy just means that all of this is being caused by an underlying lung disease, maybe bronchiectasis, tuberculosis, emphysema, but it could also be lung cancer. So when HPOA pops up on the exam, get that chest X-ray. Let's finish up these paraneoplastic syndromes with squamous cell lung cancer. Over at the squamous tile-lined cell, you should immediately recognize that elevated calcium cup of ice cream. Yep, it's our recurring symbol for elevated serum calcium. First thing to check with any hypercalcemic patient is the parathyroid hormone level. High PTH means hyperparathyroidism is the likely cause of the hypercalcemia. Suppressed PTH means that the hypercalcemia is PTH independent. And that's what you're going to see in the setting of lung cancer. Just take a look inside the cell. See that PhD badge? That's not a prisoner in there. That's the resident psychologist, out cold on the floor. At Sketchy, PhD is our recurring symbol for PTH, a PTHD, if you will. And he's knocked out. We're talking low PTH here. So if the hypercalcemia is not coming from the parathyroid, where should you look first? Well, it turns out that the most common cause of PTH-independent hypercalcemia in the inpatient setting is what's called humoral hypercalcemia of malignancy. It's a fancy way of saying that the tumor is making its own pseudo-PTH instead, a PTH-related protein, or PTHRP. So, he's fooling the guards by dressing up as the PhD, and he makes his escape. So, if you have a patient with a mass in their chest and a really high serum calcium level, especially if they're clinically displaying the stones, bones, groans, and psychiatric overtones of hypercalcemia, make sure you check that old PTHRP. Phew, that was a doozy. Cool twist ending though, right? The old PTHD switcheroo. Let's look at the big picture. There are 4 main subtypes of primary lung tumors. Small cell and squamous cell, usually located more centrally, in the central cell block. And then we've got large cell and adenocarcinoma, usually located more peripherally, out in the yard. The centrally located tumors cause some special symptoms, including hemoptysis, cough, and pneumonia. If it extends into the mediastinum, watch out for superior vena cava syndrome. And if the tumor reaches up into the superior sulcus, sound that Horner syndrome air raid siren. The most heavily tested material will be the paraneoplastic syndromes. Small cell does all those neuroendocrine ones, like Lambert-Eaton, SIADH, and Cushing's, while squamous cell prefers the old PTHRP Texas two-step.